Good afternoon and welcome to our webinar on Fostering Connections in Health, Oversight and Coordination of Health Services. We are so pleased to have you all on the phone with us today for what we hope is going to be a really informative session on the health-related provisions of the Fostering Connections Act. My name is Marcy McCoy Roth and I work at Child Friends and am representing the Fostering Connections Resource Center today. On the phone with me are representatives from several organizations who have been closely involved with supporting states' implementation of the health-related provisions of the Act. I'd like to introduce Chris Chytraus from Utah's Fostering Healthy Children Program, Jackie Scott from the National Academy for State Health Policy, Sarah Springer from the American Academy of Pediatrics Task Force on Foster Care, and Betty Ward-Zuckerman from the U.S. Government Accountability Office. We have a very busy hour planned for you today, and I'd like to give you a quick overview of what we hope to cover. First, I'll highlight some of the features of the GoToWebinar software for those of you who may not have used this software before, and talk briefly about the Fostering Connections Resource Center and the importance of the Fostering Connections Act. And then I'll turn the presentation over to Jackie Scott with NASHV, who will give an overview of the health-related provisions of the law. Next, Betty Ward-Zuckerman with the GAO will follow, and she'll review a recent GAO report on state practices for assessing health needs, facilitating service delivery, and monitoring children's care. Next up will be Chris Chytraus, who will provide a state perspective on the implementation for us, as she reviews Utah's Fostering Healthy Children program. Then Dr. Sarah Springer with the AAP will highlight resources available through their Healthy Foster Care America website. And finally, I'll return for a few slides just to wrap us up. But before that, I wanted to highlight a couple of logistical items and a couple of features of the GoToWebinar software. The PowerPoint presentation we show today will be available for you to download after today's session at fosteringconnections.org. We will also add an audiovisual file of the webinar in the next couple of days so that you can rewatch the webinar or forward on to other colleagues who may have interest in this. So on your screen, you should see a vertical control panel that looks like the picture on the screen right here. And I'll just point out a couple features that may be helpful to you. First, if you want to minimize the control panel so it's not covering up a portion of the screen, you can just click on the arrows you see on this little grab tab here where the red arrow is pointing. And that will hide the panel. And if you want to bring it back at any time, just click on those arrows again. Also, you'll notice that there's a box labeled questions about 2/3 of the way down the panel. This is how you can communicate with us during the session. Because of the large number of attendees that we have on the phone today, everyone's phone line is automatically muted throughout the session. But we definitely encourage you to submit any questions or comments to us during the session. And you can do this just by typing a question in the text box here and hitting send, which transmits the question to us. And we will try to respond to as many of those questions as we can during the session. We'll be doing that in writing. But if we are unable to get back to you within this hour, we will follow up after the session by producing a Q&A document, which will be posted on our site. And we'll probably be sending out an email to all of you as well. So there may be varying levels of familiarity with the Fostering Connections Resource Center of folks on the phone today. So I'll just take a couple slides to talk a little bit about who we are and what we do. The Resource Center's mission is to support implementation of the Fostering Connections Act by providing reliable and timely tools and information about the Act in order to support decision makers across the country to make sure they're well informed and help them as they plan for and carry out implementation of the Act. We're made up of a national network of organizations, and our goal is really to connect implementers with the latest information and the best experts and advocates across the country working on these issues. The Resource Center is supported by a consortium of 9 funders, and they're listed here at the bottom of this slide. So we're very grateful to these groups. We serve a lot of different stakeholders, and we do many different things in our efforts to support implementation, including maintaining the website, which is basically a clearinghouse of tools and information on all the provisions of the Act. Again, it's fosteringconnections.org. The website is continuously updated as organizations that we're involved with and who are involved in implementation share their resources with us. And we welcome the opportunity to feature any new resources or to share interesting or innovative state approaches to implementation. So if you have anything like that, please let us know. The Resource Center also provides, or brokers, customized, individualized technical assistance. We have a vast network of collaborating organizations and partners who are focused on the implementation of all aspects of the Act. So we are at the ready to work with you individually or to connect you with one of our partners or collaborators who can work with you to ensure that you're supported as you do your work to implement the law. Our third major focus is monitoring implementation activity around the country by doing a variety of things. We share state or tribal approaches to implementation with the field by featuring these things on our website. We also keep you abreast of any federal guidance that's been issued on the various sections of the Act and keep updated timelines of when the various provisions of the Act become live. And finally, the Resource Center serves as a venue for interactive communication between stakeholders and content area experts about the law and its implications. We have a mailing list, so you can subscribe to this on the site, and that will keep you informed through our monthly newsletters and the research briefs that we've been doing. We also have a calendar of events and conferences up there that you might want to check out. And we have a new discussion forum that we're using LinkedIn to manage. And you can join this group and ask questions of your peers or directly to topic area experts. Or if you just want to share a comment or concern from the field to the larger audience of folks who are working on these issues. So you've heard me mention our collaborators and our partners a couple times already, and this slide just gives you a quick look at who these folks are and who are helping us stay connected to the field's questions and concerns. The Resource Center is divided into 6 major networks based on the main topic areas of the law, as you see right here in the second bulleted list. Each network has an in-house manager from the Resource Center, and then each manager works with a network lead organization, which, as you can see, is a national organization with expertise in that area. And I'm representing the Health Network and work with the National Academy for State Health Policy, who we have on the line today, and who's been the key organizing force behind this webinar. In addition to our network leaders, we also work with a group of over 25 national organizations who serve as collaborating partners to the Resource Center. These organizations were involved in the passage of, or with implementation of the law, and they're really a critical part of the work that we're doing by helping us stay abreast of the needs of the field and helping also in communicating dissemination of different information out to the field. In addition to these national collaborating organizations, we also feature resources and contact information for state and tribal-based organizations on our website. So you can go to our website and search by state to see what different states are doing and what tribes are doing in different states. So we invite you to check out our website and to contact us if you have any questions. And also if you have an organization that you represent that you'd like to be featured on the website, please let us know that as well. But before I pass the presentation over to Jackie Scott with NASHB, who will go into some details about the health-related provisions of the Fostering Connections Act, I just want to give a brief refresher on the law that we're focusing on. The Fostering Connections to Success and Increasing Adoptions Act was signed into law on October 7th, 2008, so we're approaching the 2-year anniversary of its passage. And it represents, some say, the most sweeping and comprehensive federal reform in more than a decade for children and families involved in the child welfare system. Improving health care services and coordination for these children and youth is one of the several significant enhancements to practice of policies that came from this law. We ask that as we go through this presentation that you just keep in mind the populations of tribal children and youth and their families who were also impacted by various provisions in the law. We encourage you to consider this population as you work with the health-related provisions of the Act to ensure that their needs are equally accounted for and addressed. The Fostering Connections Resource Center contains a special section devoted to tribal children and youth, so please visit the site for resources and other tools. Okay, so I think I'm ready to pass this over to Jackie. Thanks so much for being here, and we hope you enjoyed this session.
Thank you, Marcy. I really appreciate that. Hello, everyone. This is Jackie Scott from the National Academy for State Health Policy, located in the Washington, D.C. office, and I'm delighted to be here with you today to talk about the Fostering Connections Act and specifically the health provisions. Next slide. Before I begin, though, I want to talk to you a little bit. Let's just let those of you who are not familiar with NASHB know a little bit about who we are. We've been around for about 22 years now, and we are a nonprofit, nonpartisan organization. Our members are referred to as Academy members, and they are all peer-selected groups of state policy leaders throughout the country, and they work to help guide our work here at NASHB by committing their time to identify state needs, review documents, and serve as advisors on projects with us, and then to participate in our larger events like our upcoming national conference the first week of October in New Orleans. So our Academy members are very involved in charting NASHB's course and continue to be throughout the years. We work together with our members and with leaders across states, all branches and agencies in order to implement workable policy solutions that address the major health issues of the day. Next slide. With regards to fostering connections, NASHB serves as the lead partner for the Health Network and for the Health Network Resource Center in particular. We are able to provide both consultation, advice, but also research, analysis, and information on issues that are pertinent to the foster care population through our interactions with the Resource Center. But this is not the first work that we've done in this area. Our work over the years with regards to foster care children and foster care related projects include work that we've done to improve systems of care across systems, health and human service systems for vulnerable youth, including those in the juvenile justice system and those in the foster care system. Next slide. So what are we talking about today? Well, there are lots of important provisions in the Fostering Connections Act, and some are listed here. But today we're going to really focus in on the coordinated health services that are highlighted in the Act and the requirements associated with those health services. And there are a number of other webinars that the Resource Center has put on dealing with each of these other items, and I know those resources are also available, and I encourage you to take a look at those. But today we're going to focus on health. Next slide. There are a number of state requirements regarding health oversight and coordination planning in the Fostering Connections Act. The pertinent section of the provisions governing the Oversight Act, governing oversight and coordination is Section 205. Next slide, please. So with regards to Section 205, Health Oversight and Coordination Planning, there are a couple of key requirements we'd like to highlight for you. First and foremost, states are required to coordinate with Medicaid agencies as a result of this act. And it's important to note that this includes other state agencies that have state Medicaid plan responsibilities that are linked to foster care. So it's important to note that coordination at this juncture is key. And so the focus is really on developing those plans to respond to the needs of kids in the foster care system. And that includes, making sure that the coordinated agencies are working together and are explicitly developing plans that move them in that direction. Next slide. The Section 205 is very explicit about what development of plans means and what is supposed to be included. This slide lists what's required for coordination of plans and what should be in them. And I just want to highlight for you a few things that we think are very important as you think about how to do this work. Items 1 and 3 on this list are really linked to care continuity. There are specific requirements that the plans talk specifically about the follow-up health screenings and the monitoring and treatment of this population, and to make sure that steps are taken so that the continuity of health care services that are needed for the kids in the foster care system is being received and is being planned for. Some of this is anticipated, as you see explicitly in item 3, around the establishment of medical homes. So this links to, very nicely, to the opportunities that states are already engaged in developing medical homes, and is an opportunity to ensure that the safety net for these kids exists. Then I'd like to highlight for you item 2, which is also another opportunity to link services that this population requires to ongoing efforts in the states right now. It's around information technology and the creation of the kinds of systems that will allow states to appropriately share information, medical systems to share medical information for these children. And this is important because it links directly to and has implications for the work that states are doing around health information technology, health information exchange, and the opportunities there are to really develop things like electronic health records that can also link back up to ensuring that kids are getting the continuity of care that they need as they move from placement to placement, person to person. And so that is a big piece that I also would like to highlight. And then finally, states are really being asked to think thoroughly about how they will engage and develop relationships with both medical and non-medical personnel. And this is important because they're going to be asked, and are currently being asked through this act, to explain in coordination plans how those linkages will take place to, again, ensure that youth are getting and receiving the care and the access to providers that they need, and the appropriate assessments by the appropriately designated folks who are able to provide those services. Next slide, please. So as we all are contemplating what health reform means in many different ways in our states and in our daily work around health care, there are also some relevant highlights linked to health reform for fostering connections. And so I'd like to highlight a couple of them very quickly for you. In June, guidance was issued for states, and this guidance focused around providing and describing what states and American Indian tribes need to do to comply with the Act. And there are 3 areas that were specifically highlighted: issues around transition planning, oversight and coordination plans, and the foster care independence program. So I'm going to go through each of these briefly just to let you know what those specific areas were. Next slide, please. So first and foremost, the transition planning. As you see in the previous slides, there are a lot there. There's a lot there with regards to the requirements of the transition plans. But this is a really important piece. The personalized transition plans for children who are transitioning out, 18 years or older, can now include information such as a designated healthcare advocate for children listed in the plan, things like making sure that there's a designated power of attorney is now an option, and or a healthcare proxy depending upon what your state law allows and requires. And the effective date for this to begin to take place is October 1st, 2010. So your transition plans can now begin in a couple of weeks to begin to include these items. Next slide, please. Next, there are provisions and requirements related to the healthcare oversight and coordination planning. And this is important because there's now a requirement that options be provided for these youth who are transitioning out of the system, so that we include in this planning process some discussion of what kinds of health care options are available for them, that children are just not transitioned out without any options given to them or any care provided for them. So the plans for how states were going to do this were to be submitted to their regional offices in June of this year, and with the plans being able to begin to be effective and taking place again in October of, well, next month, October 1st of this year. Next slide, please. Next, there were some direct relationships in health reform to requirements around foster care independence program. These requirements focused on making sure that youth transitioning out of the system be provided with some background information and education on what it really means to designate a health care representative. And this puts them in a better position of understanding and being able to actively engage in their transition planning as they move out of the system, as noted in the first requirement a couple of slides ago around what has to be in now, or what is allowed to be in now, the transition plans for youth. Again, with an effective date to begin in October of this year. Next slide. And finally, there is the expansion of Medicaid coverage for former foster care children. States are required now to extend Medicaid coverage up to age 26 for these youth who have aged out of the foster care system. And this is a big piece that states have to prepare as they prepare for all the other Medicaid expansions required in the Act, that they need to include this population. This effective date is much later and relates to and links with some of the other Medicaid expansions found in the Act, and isn't required to take place until January of 2014. Next slide, please. So that concludes my overview of the health provisions in the law, and it gets us to at least a level of detail and context for our upcoming speakers, and helps you to begin to think about the kinds of questions you'd like to know as you're developing and moving forward in your state. Here is my contact information at NASHB and our website. You should feel free to access the website for additional materials and submit your questions, and we'll be sure to try to answer all of them, if not at the conclusion of this webinar, shortly thereafter. Marcy, I'll turn it over to you now. Thank you.
Thanks, Jackie. My name is Betty Ward-Zuckerman. I'm with the Government Accountability Office, which is an independent federal legislative-based agency that conducts research, evaluation, and audit, which you may be more familiar with as GAO. As Jackie outlined, in October 2008, Congress expanded requirements related to federal funding for foster children. It specifically required that states explicitly plan for oversight and coordination of health care services for children in foster care. In connection with introducing that legislation, Chairman McDermott of House Ways and Means Subcommittee on Income Security and Family Support asked the GAO review state practices in that area at the time. Based on that request, GAO issued a report in February 2009 titled Foster Care, State Practices for Assessing Health Needs, Facilitating Service Delivery and Monitoring Children's Care, which I'll be briefly summarizing today, and which is available for download on gao.gov or through the Fostering Connections website. Although the practices described in the report were in use before the expansion of federal requirements, they address some of the new requirements and may be helpful to other states considering changes in their plans spurred by the new legislation. Specifically, GAO described practices that selected states had adopted to address the challenges of identifying foster children's health care needs, ensuring delivery of appropriate health services, and documenting and monitoring foster children's health care. Before I describe those practices, I just want to say a few words about how we did this. To compile the report, we visited state officials and other stakeholders in Utah, from whom you'll hear shortly, as well as Illinois and New York, and we reviewed additional practices in 7 other states: California, Delaware, Florida, Massachusetts, Oklahoma, Texas, and Washington. Our work was designed primarily to describe selected states' practices, and we discussed these practices with a range of stakeholders and reviewed related research and data. However, we can't generalize the results of our review from the 10 states we selected to all states, and we didn't evaluate the actual operation of each practice. The report includes a range of background on related materials and what was known about the health status of children in foster care at that time, but I'll be focusing mainly on our findings related to state practices. We identified state initiatives in 3 areas that I'll review in more detail, and those 3 were specific requirements for assessments and use of designated providers, practices to enhance access to services, coordinate care, and monitor use of medications, and mechanisms for data management and quality assurance for documenting and monitoring children's health. First, with respect to addressing the challenge of identifying foster children's health care needs, we found that all 10 states we studied adopted policies that specified the timing and scope of children's health assessments. Although ACF hadn't imposed specific requirements for health assessment upon entry to foster care at that time, the 10 states we selected for study required that children have a general physical within 30 days of entering foster care, in line with recommendations from professional associations. States organized these initial assessments differently. Florida, Illinois, Massachusetts, and New York conducted assessments in 2 stages: an initial screening within 24 hours and a later fuller assessment within 30 days of entry. California, Delaware, Oklahoma, Texas, Utah, and Washington invoked a 1-stage assessment process, which was completed within 14 to 30 days of entry. Following entry, 6 of the 10 states called for children in foster care to receive at least annual screening, either under a separate health standard that was applicable to foster children, or because the state's early and periodic screening, diagnosis, and treatment standard, or EPSDT standard, for all Medicaid enrollees called for at least annual screenings consistent with the 2008 American Academy of Pediatrics recommendation on preventive pediatric care. 8 of the states we selected for study required screening of mental and developmental health shortly after entry. For example, Delaware reported that since February 2006, its initial health screening had required the inclusion of a component alerting staff to any mental health or substance abuse issues for children 4 through 17. Those states varied in use of specific time frames or specific instruments for mental health assessment. To conduct these health assessments, some states use specially selected, trained, or dedicated personnel to increase the likelihood that children received appropriate health care services. States commented that use of a specific network of physicians facilitated quality improvement and training to enhance the thoroughness and consistency of assessments. A few states reported having a mental health specialist work with caseworkers to conduct assessments. And in that connection, one survey found that involving mental health specialists in assessment resulted in greater identification of mental health needs, as well as improved follow-up. We noted, however, that the scope of mental health assessment varied widely from comprehensive social assessments to asking about indicators of mental illness. Specific research and state officials' testimony indicated that these policies and practices allowed provision of higher rates of screening and referral and more rapid follow-up. Where there are explicit and comprehensive policies mandating assessments of all children entering care, greater percentages of children are likely to be assessed, according to a survey of nationally representative sample of child welfare agencies. Further analysis of those survey data showed that agencies with comprehensive developmental screening policies were more likely to evaluate children, refer them to intervention agencies, and engage in joint planning of healthcare services. States also identified practices to enhance foster children's access to medical care, coordinate their care, and monitor use of medications. Specifically, because removal of a child from home can change Medicaid eligibility status, some states have taken steps to hasten documentation of Medicaid eligibility. These states provided temporary cards or used specialized staff in their child welfare or Medicaid units to ensure that children in foster care were quickly reviewed for Medicaid eligibility. They reported that this practice reduced time required for eligibility documentation by days or months. To encourage more physicians to provide needed care to foster children and to compensate physicians for an increased standard of examination, Illinois and Washington reported increasing payment rates to physicians for children in foster care. In addition, Utah, Illinois, and New York instituted a variety of programs to increase access to medical specialists and subspecialists. For example, in rural areas, these programs included use of traveling clinics to increase access to specialists among children with special health care needs, provision of necessary transportation, and consideration of telepsychiatry. In addition to make best use of available mental health resources, Illinois had developed a psychiatric crisis hotline for all children who receive Medicaid or other public funding for medical care to screen for hospitalization and arrange for community-based follow-up care for callers. And finally, New York had launched a program in early 2008 under a Medicaid waiver to provide community-based services to a fixed number of foster children with developmental disabilities, serious emotional disturbances, and medical problems that might otherwise have required more expensive residential services. Significantly, some states employed nurses or other healthcare professionals to ensure that children in foster care received necessary healthcare services. These staff were often public health nurses, but in Illinois, the State Child Welfare Agency or a local contracting agency served as a healthcare manager. Services provided by these case managers included, or care managers, included development and maintenance of the child's health history, identifying the child's medical needs and arranging for receipt of medical services, and identification of professionals available to serve children in foster care. Officials in these states indicated that such care coordination had increased rates of immunization and speeded initial assessment and comprehensive assessment or well-child visits. An evaluation in New York also pointed to positive effects on receipt of initial physical and dental exams, access to non-preventative care, and health-related contacts between caseworkers and foster parents. Healthcare managers also sometimes provided additional services, such as assisting foster parents or caseworkers with medically complex situations or implementing reminder recall systems for foster children's preventive healthcare needs. Finally, 6 selected states identified practices for monitoring use of psychotropic medications, usually by requiring an extra level of official, judicial, or expert review beyond the prescriber. Use of such medications is challenging in foster children because those who change placements often do not have a consistent person to plan treatment, offer consent, and provide input on treatment effects. For example, Texas required a review of prescriptions in certain circumstances, such as when multiple psychotropic medications were prescribed at the same time. Administrative data associated the introduction of this policy with modest decreases in prescribing psychotropic medications and declines in specific patterns of prescribing, such as prescribing multiple medications at once. The Texas policy emphasized a complete assessment before medication was prescribed. Alternatively, the Judicial Council of California has adopted rules of court to implement a requirement for judicial review of certain psychotropic medications. Court approval must be obtained within 2 days in cases where they're used on an emergency basis. Similarly, Illinois and other states contracted with universities or other experts to provide independent review of psychotropic medication requests to ensure safe and appropriate use. In the last area I'll discuss, we documented a range of state practices related to data management and monitoring the health of children in foster care. Specifically, some states reported sharing health data across programs. The goal of states' healthcare data sharing initiatives was to enhance access to existing healthcare data among parties responsible for the health of children in foster care while meeting data security and privacy requirements. In Texas, these data sharing efforts included a foster care health passport that electronically compiled data on a specific child from multiple data systems, such as immunization records, S-chip claims, and data on prescription medications. This allowed continuous updating at many points of care and permits access through a secure website by multiple parties with decision-making responsibilities for the child's health care, including children's caseworkers, foster parents, and healthcare providers. In contrast, most states that we reviewed reported using a combination of electronic and paper-based data sharing to obtain information other state agencies had compiled on children prior to their entry into foster care to provide more complete and timely medical histories than otherwise available. However, these states provided more limited access to these data, and updates typically relied on the exchange of paper reports about medical visits and their results among doctors, foster parents, and caseworkers. Finally, 3 states and a major city within another state pointed to various quality assurance mechanisms to track receipt of services. Monitoring procedures that aggregate information across foster children can help managers ensure that healthcare policies are consistently implemented and having the intended results. ACF's reviews found that states with identifiable quality assurance systems that conform to specific criteria had a higher percentage of cases rated as having met the health needs of children in the state's custody. Further, ACF's analysis suggested that states with well-functioning quality assurance systems were more likely to succeed on measures of enhancing a family's capacity to provide for the needs of their children and ensuring that the children's physical and mental health needs were met. For example, officials from some states we studied, such as New York, Utah, Delaware, and Illinois, cited specialized case reviews focusing on children's receipt of health care services as supports in monitoring child welfare agency performance in meeting the health needs of children in their care. And any questions that about that aren't answered today can be addressed or routed to me through the staff at Fostering Connections or via email to wardzuckermanb@gao.gov. And with that, I'll turn the mouse over to Chris Kreitis for more information on the many initiatives that Utah has pursued.
Okay, Chris, you have the mouse.
It's a pleasure to be with you today and share some of the things that we're doing in Utah. Our program has actually been in existence since approximately 1994. The day that Governor Leavitt took office, a lawsuit was filed by the Youth Law Center in San Francisco, known as the David C. lawsuit. And one of the primary things that they were looking at was that children were in foster care and were languishing without health care needs being met. We finally, after 14 years, were able to exit out of that settlement agreement in December of 2008. What Utah has done is, between the Medicaid agency, which is also in the Department of Health in a different division, and children with special health care needs, we've developed a memorandum of understanding between the Division of Child and Family Services and the children with special health care needs that co-locates public health nurses in offices with the DCFS caseworkers. So those RNs will partner with the caseworker to provide oversight of the health needs of all children in foster care while the caseworker provides the case management piece. The nurses gather, evaluate, and document the health history on each child in foster care. They obtain that history from the biological parents, previous medical providers, family or friends that happen to be involved with the child, and depending on the age of the child, some information will actually come from the child. They then track the ongoing health care of each child that enters care in their respective office assigned and whatever cases they're assigned to. And we do that based on the periodicity schedule that is recommended by the American Academy of Pediatrics. So in Utah, the medical side, if a child comes in immediately on entry into care during the CPS investigation or Child Protective Services investigation, if they have any injuries, if they're sick, or they have any visible signs of abuse, they're automatically taken to an urgent care or their own primary care provider. Within 24 hours, they will be seen if they have a chronic medical condition or if they start having any complaints. And then every child is required to have a comprehensive medical exam within 30 days. We attempt to get those done within 14 days if we can. We also attempt to send the child back to their medical home. So we try to keep them with whatever provider they were with prior to entering foster care, because we believe, number one, if the child's going to be reunified with their family, they'll be returning back to that provider, and it's best to keep them as a familiarity in the family that knows the child and the family. If that's not possible or they don't have a medical home, then we will establish one for them when they enter care. The dental exams, every child 3 and above is required to have an annual dental exam that includes x-rays and prophylaxis. If there's children that are identified during the well child check that's under 3 that has bad tooth decay, they too will be seen by a dentist. Mental health on children prior to age 4 months, we rely on the primary care provider to assess them developmentally. From children ages 4 months to 5 years, we will send out the Ages and Stages and the Ages and Stages social emotional tool to have the foster parent complete for the child and send back to us. We then score both of those and we'll make referrals to early intervention or Head Start based on any developmental delays that are identified. For those children that are older than 5, we require the comprehensive mental health assessment for all children, and that's done from 5 until they leave care. Annually, the health care requirements are a well child check, the dental exam, the mental health assessment, or the Ages and Stages. And then we also track any follow-up health care referrals that the medical home or the dental or mental health person has made a referral to. And we require that those are completed within 90 days if at all possible. Some of our subspecialties, neurology, things like that, we may not be able to get them in the 90 days. But if that's the case and it's urgent, we'll have the physician that made the referral talk to the referrer. Utah's also implemented what we call our health status outcome measure. This is a tool that we utilize that shows point in time what the child's current health status is. So a nurse makes a call to the foster parent. They are completed at 1 month, 3 months, and 6 months. And then the nurse is prompted following the 6-month one based on the score. So those that are more medically fragile are done every 2 months. Those children that are more healthy, we may only contact the foster parent mandatorily every 6 months. That doesn't mean we don't have more contacts with them, but we complete this tool minimally at that point. This is just a sample to show you over since 2005 when we've implemented it, where we are. The 1 and 2 are children that are healthy, that are on no medications. The only differentiation is the 2 children in the 2 category require mental health, and we separated them out because in some of the rural areas we were trying to track access to getting them the mental health services that they needed. There's a document that will be posted on the Fostering Connections website that will show you all of the categories and how we score those. The 5s are the children that are the most medically fragile, and as you can see, we have fewer of those. Those could be kids that have had transplants, severe diabetics. And the 4s are those that are on psychotropic meds. We specifically put them in that category because we do want to monitor them more closely. As far as medication tracking, we have a database that we track all of the children's health care. It's called SAFE. It was used with the federal SACWIS funds to develop. It is available. It's public domain. It's just finding people in your area to be able to provide the support that it needs. And I can provide information if you're interested at a later time on how to access that database to at least have it, be able to look at it. As far as the psychiatrist, if there's concerns about a medication that a child's placed on, we have psychiatrists available that we can staff our concerns. We can always get second opinions. as an example, Utah, the legislature wanted to know what group of children were being prescribed psychotropic drugs. So in 2008, we did some data polling, and there were 2,651 children in custody. Of those, 833, or 31%, were receiving psychotropic meds. What we found, too, was there were over 140 licensed providers. This was important for our legislature because they were concerned that we were sending them all to the same provider and they were all being prescribed the same medication, and we were able to show that they were not. When there was the recall back a few years ago on Effexor and Paxil, we can pull those medications that have any recall from the FDA. We can pull not only the medication but also the provider, and we were able to send a letter out similar to this, alerting the provider that the child was in foster care, that our records showed that they were on that medication, and that because of the FDA black box warning, we asked that they would see the child and review the medication to whether it should be continued or not. And we've been able to do this. We've had some other medications that have been recalled by the FDA, not psychotropics, but others that we are able to pull that information and share. Our SAFE database, just quickly, I'll let you know, we track all of the visits that the child has, medical, dental, mental health, any follow-ups. We can see their mental health, access, diagnosis, treatment. We track their ASQ scores. It's been interesting because we can, on kids, the data that this gives you is phenomenal. Kids that come in that are drug exposed, we can see how they do developmentally. If they come in and they're neglected, we can see how their neglect, if it gets better once they're placed in a nurturing environment. We track medications, allergies, all the immunizations, history both on the client and the family, MI-706 and the Medicaid information, and all the healthcare providers that they've seen, so that we can make sure if a child happens to be in care, go out of care, and come back, 1 or 2 years later, we have that history available to us to fall back on to track down the providers that they've been seeing. I do have some forms, but because of time, I'm not going to show those. They are going to post those on the Fostering Connections website. We have the scoring sheet on the health status outcome will be there. There's a health visit report form if you need something for the foster parents to take to the doctors. These are just items that I think we've developed that may be helpful for you to use, so we don't have to redevelop the wheel. So feel happy to contact me. My email address and my phone is there, and I'll be happy to answer any questions that I can for you. So I will turn the time over to Sarah.
Okay. And
okay, Sarah, you have the mouse now.
Right, trying to make it advance our slide. There we go. So I'm Sarah Springer. I'm a pediatrician in Pittsburgh and the chair of the American Academy of Pediatrics Task Force on Foster Care. About 5 years ago, well, let me tell you first, the American Academy of Pediatrics is a nationwide organization of pediatricians from all over the country dedicated to the health and well-being of all children. As part of an ongoing process of looking at priorities for the organization, the Academy made the health needs of children in foster care a strategic priority for the organization about 5 years ago. As part of that effort, the Academy created the Task Force on Foster Care that was tasked, that it's a group of AAP members, pediatricians, as well as collaborators from a variety of other child welfare professional organizations. And we were tasked to look at the health needs of children and youth in foster care on a systems level, look at policy things that where health was an issue, look at the community level of care, and look down to the individual practice level at the quality and access to care that children had in pediatric practices. On a policy level, the Task Force on Foster Care worked significantly with members of Congress in writing those the health portions of the Fostering Connections Act, and the 5 requirements that Jackie went through on slide 15 were ones that we helped to write because we agree with Jackie and how she said it, that those are things that are important to seeing both on a systems level that all children in care are getting the care that they need, as well as trickling down to the individual child level, that those are important. So in talking to our various collaborating partners, we first started with looking at feedback for what are the health issues perceived by caseworkers, by judges, by foster parents, by youth themselves who either are in or have been in care. And the thing that came out loud and clear as the most important issue from the perspective of all of those people was that access to quality pediatric care was a big problem. And so we've put quite a bit of effort into educating our pediatric population, our members, on the specific what are the health needs that are commonly seen among children and youth in foster care, and what do we know about how to address them, and how to work with other organizations, how to collaborate with other child welfare professionals to work together to meet the health needs and to overcome barriers to meeting those needs for kids. It also came out that just access to care was an issue, that there were many foster parents in particular and a lot of caseworkers who felt that they had a very difficult time finding a pediatrician or family doctor who was willing to provide care for their children in foster care. And many foster parents even said, you know, I can bring my biologic children or my children who are adopted who are on my health insurance, I can bring to any pediatrician I want, and I can't take my foster care children. I end up taking them to the emergency room because I can't get them into a pediatric practice. So we've put a lot of effort into educating pediatricians and encouraging them, getting them excited to want to open their doors to bring children into their practices. We've had quite a few educational events. We dedicated a half-day conference this time last year towards meeting the health needs of kids in foster care. And we're really starting to see more and more throughout the country examples of pediatricians who are doing just that. So we're pleased with that. The American Academy of Pediatrics has a chapter structure. We have at least one chapter in every state. Some of the larger states have two, and there are two military service chapters as well, which is important because kids in the military, like somebody mentioned earlier, that kids in tribal communities have special needs. Kids in the military have special needs as well when they come into contact with the child welfare system. We are, as part of our ongoing policy and community level work, we are working hard to both equip pediatricians in our chapters to be resources to each state as states go on to develop these systems to meet the mandates in fostering connections. We want to have our chapters and our pediatricians be collaborators in those processes, both to provide health expertise as the policies are made and implemented, and to be a liaison back from state level working groups back to pediatricians and family doctors in the community who in many cases will be the ones to provide the care to individual kids. We're in the process of identifying foster care champion pediatricians in every state who will be able to be a contact person in that two-way liaison back and forth between other organizations and pediatricians. We have created quite a few resources. The Academy has committed quite a bunch of time and effort into creating resources for chapters to help them learn all of the kinds of things we're talking about today, about other resources that are out there and what other people are doing to meet the needs of the health provisions in fostering connection. So there are resources that are continually being updated, similar but with a particular pediatrician perspective and office practice perspective to the GAO documents that were mentioned earlier, but there are ongoing assessments of what different states and what different practices and different communities are doing to meet these needs, and the website link is there, and those continue to be updated over time. Wanted to specifically let everybody know about our website that went live just about a year ago now. It's Healthy Foster Care America, and the link is there. This website has information on health needs of children in foster care for all different constituencies. Oops, okay, there we go. We have information specifically on health issues, particularly looking at common health issues that we see for kids, you know, what what do you need to know about asthma if you're a foster parent and have a new child in your care with asthma? What do you need to know about taking care of a child with diabetes? We also have lots and lots of information on developmental, mental health, and behavioral issues that are common to kids in care. So how do you handle encopresis, or how do you handle temper tantrums, that sort of thing. So there's lots of resources there for caseworkers and foster parents and birth families as well. There's a listserv available, and you can sign up through the website for clinicians and those working on on state and federal level health provisions. So if people want to join that, we'd love to have you join to communicate with other professionals around the country about what you're doing. There are resources for children and for teenagers on there as well that people have found to be very healthy or very helpful. And we're continuing to update and add new resources all the time. This is a work in progress. There are, as I said, fact sheets, and the American Academy of Pediatrics has just oodles of information on every different health issue you can think of. We have made it a point, as we've talked about health needs for kids in foster care right from the beginning, we've referred to it as health with a capital H. So we don't just mean their physical health and are their shots up to date, but their oral and dental health, their mental and behavioral health, developmental and educational needs. And having all of those needs met are really what it means to be a well child in the big picture. So we absolutely have every intent and mean to make our health concerns broad-based and well-rounded, and there are resources to talk about all of those issues on the website. With regards to developing systems of care, there is information on the website again about developing healthcare standards and how do you address barriers to good care. In our original research and information gathering, that was the next thing down the list that came up after access to quality care was the barriers that exist to meeting those healthcare needs. A big piece of it has turned out to be having physicians and caseworkers and judges being able to communicate with each other, as some others have already alluded to today. There are privacy concerns, of course, but also very important communication that needs to happen if judges are to understand how health needs for children are impacted by their placement or need to impact placement decisions. If caseworkers and judges understand where children's health needs and having those health needs met impact their permanency chances. And in order for all of those issues to be considered, different professionals need to communicate with each other. And what we found is that different cultures and different languages and different professions create significant barriers there. So there's a lot on here about learning each other's languages, understanding how to communicate. We have tools, and Chris mentioned forms. We have a number of forms that are very similar to the Utah forms too, for communicating back and forth between physicians, foster parents, caseworkers, judges, other health professionals. And we welcome people to download those and use those. So there, I just said that. We're running out of time, so I'll be quick here. So here's our contact information. Moira Zalaji is our other co-chair, vice chair of the task force. Some of you may know her in New York State. And Mary Crane is our staff person who is in charge of all things related to foster care at the American Academy of Pediatrics. So you can reach any of us through there. And we'd love to hear from you. And thank you very much. I'll turn it back to you, Marcy.
Great. Thank you so much. Thank you, Dr. Springer, and thanks to all of our panelists for really a wonderful overview of the Act and what states and national groups are doing to support implementation. I learned a lot, and I hope that was helpful for others as well. I also want to do a quick thank you to Carrie DeVoe for her outstanding work getting this webinar together and getting us all organized and technically prepared. So thanks to that. A couple more resources and announcements I want to share before we wrap up. First, I just want to encourage you to write us with questions at the Resource Center. You can contact us at info@fosteringconnections.org. We can also help broker or provide technical assistance if you have specific questions. So please, use us as a resource. That's why we're here. I also wanted to mention that we, have many, many resources on our website. You've heard a lot of different tools today already. We have over 500 different state and national resources. A few that are listed here are specific to health. We've already talked about Healthy Foster Care America at AAP and Utah's great program that they've been doing. The GAO report's highlighted here. I also wanted to mention Policy Lab at the Children's Hospital of Philadelphia. There's a lot of great research that's showcased and summarized there. On our website, I wanted to do a quick highlight of the Foster Club's Transitions Planning Toolkit. Jackie talked about transition planning a little bit, and this is really a terrific resource and sort of a all-in-one tool for helping kids who are transitioning out of foster care think about what their health needs are going to be. And it's something that Foster Club put together, and it was youth-informed, so I think this could be a helpful tool for you. Finally, just wanted to mention again, copies of this presentation are already up on our website at fosterconnections.org. An audio recording will be available shortly. Our next webinar is going to be in October 7th, which is the second anniversary of the Foster Connections Act. It will be on an older youth related topic. Again, we have a LinkedIn group discussion forum. If you'd like to join us, please look up Foster Connections Implementation Working Group, and we'd love to have you and any questions that you might have. Our contact information, again, is highlighted here at the bottom. And thank you so much for coming and for sticking with us to the very end. We hope it was a good session for all of you, and thanks for all the hard work that you're doing on behalf of kids across the country.